Today's topic, we will be talking mainly of how to choose analgesics and the dosing principle. And this is one of the module of pain management module. If you go back to my previous slide, is a palliative care interdisciplinary curriculum. And we take many lectures, many teaching programs, online, offline, with the help of my mentor. If you see, my mentor is Dr. Frank Ferris, who is from San Diego. And I'm very lucky to have a person who has actually taught me what exactly is palliative medicine, how we should practically treating our patients and taking care of the patients. And also is my mentor for one of my leadership programs. So I am all thanks to him. So today's topic, we will be focusing on how to choose the analgesics and how to give this dose very effectively so that there will be good relief to our patients. At the same time, there will be minimal side effects. So before going to that, just imagine, suppose if you are suffering from pain, right? How long would you like to enjoy your pain if it is 8 by 9 out of 10? I don't think anyone would like to experience even for a second, right? If I'm not mistaken, right? So no one wants to have pain and they want to get rid of this as early as possible. So when we think that we want to get rid of pain as early as possible from our end, I hope even our patients might be thinking the same, right? So it is our role and it is our job to see to it that we give them this pain relief in a very efficient way with least side effects. So that is our role. And if you look pain, now if you see, some people call it as itself, define it as a chronic disease, but there are many factors to it. Rather than saying that as a chronic disease, I can say that it is a symptom which affects our daily things. So what we call it as activities of daily livings. Okay, it affects our functions, it affects our eating, sleeping, interaction with our spouse, with our relatives, with our children's, everything. It affects each and every aspect of our life. So one of the important teaching which I do to my postgraduate students is that I tell them we have to look into the pathophysiology and at the same time we have to look what we can do to help the patient have the best experience when they pass through this journey. So that we have to give them that good experience through this journey. So how will we give that? Okay. One thing is that either you treat the cause or you treat the symptom. And as a palliative physician, our main role is to treat the symptom so that they have a good experience, right? So they can travel through this pathway in a very comfortable way. So that is what I try to do. And what are the markers to know that? Because pain is a very subjective thing, right? If you ask the patient, he will always say, if he sees a doctor, he will say, sir, 10 में से 10 है, 9 में से 10 है. They will always try to say more so that they will get more attention. So this is my observation. No literature points it out, but this is one of my observations over a period of, I can say, almost 2 decades I am doing pain, and palliative for the past 5 years I am doing. So how we can improve? We have to see whether all these functions which are getting affected are improved when we are treating the patient's pain by the analgesics which we use. So that is what we are here, and our main aim is that to give people the capacity to continue to do the things they want to do. So this is what we can do as a palliative physician. I may not cure the disease, I may not control his disease, but at least our objective or main aim should be to give the capacity. This is a very good statement, I say, to give people capacity to continue to do the things they want to do. I agree, certain people will say, I want to go and play the cricket, I want to play the football. We may not able to do all those things, but at least some capacity to do at least their activities, daily basic activities. We can do that. And you and I always need to treat the cause, always, wherever possible. But we are going to talk about the pathophysiology and specific medications for specific situations in some another series, which we had already discussed previously, that we will be having a series and where we will be discussing these pathophysiologies. But at the same time, as I told you, always need to manage the experience of the patient. So this is what I feel is very, very important, because this is what, if you see, the patient will say that how you made me feel is what is more important than what we are given to. So when we know what to do, right? And here we do know what to do in terms of managing the experience of the pain. And if we don't do it, or if we undertreat it, that means effectively we are doing a medical torture to this patient. So, I means whenever I tell my students, I tell them that if you are not able to manage the pain, that means that is a sort of a torture we are doing. It's a sort of a neglect, I can say that sometimes. So don't you think that we have got into this profession of medicine or palliative medicine to really do a good job, right? And to care for the patients. And I feel that is our role. So concurrently, we need to treat the cause based on the pathophysiology. But currently, I will be not discussing about this pathophysiologist now. But what I will be talking more about is treating the experience by way of non-pharmacology. And non-pharmacological has to be for everyone. Again, though our main focus is right now non-pharmacological, it will be more on the pharmacological, which we will be talking. And then there are certain patients who get a good relief with interventional procedures. And if you ask my own personal experience, I don't know, because I had seen many professionals who are practicing pain. They left, right, they say that interventional pain for all patients. I have certain reservations whenever I want to do interventional procedures in my group of patients. My conversion rates are less than 1%. It will be very shocking to you if you want, but my conversion rates are very, very less. You can ask Manisha madam who had come to me, and very few procedures I do. Mostly I manage the patients on morphine, and if you adequately titrate, so that is what is our talk today. That is what I am going to tell you how to do and all those things. So coming to the pharmacological management. So my objective will be to choose the right analgesics. Then we will be talking about the dosing principle. So mostly we will be talking about the pharmacokinetics. I will be talking. And then we will talk about something called as titrating these medications using a technique called as a catch-up technique, where we will be optimizing the efficacy to give a good pain relief, as well as to see to it that they are safe enough so that they don't have very serious or adverse side effects. So to do this, let's do it in a case-based module. And this is a case which my mentor has given me, and that's many of them are his slides only, which I will be using. So let me introduce you to Bill, who is a 72-year-old male, who is a war veteran, who was suffering, who is I can see a prostate survivor from Jan 2006. His consent has been taken, and he was happy to say that to tell his story as a part of our teaching. So he has consented that we can use his entire story. So we will be talking his entire story. I think I can say another 40 minutes or so. And we will titrate and choose the analgesics based on his presentations. So by August 2009, he had bone metastasis. You can see on these PET scans. So you can see all these metastasis. Okay. So these are the areas where he's having metastasis. And if you ask me, the gold standard treatment of the bone metastasis is radiotherapy, which he has already received 20 grays, 5 fractions. But today when he presented to us, he was having pain like a severe toothache, which is a shooting type of pain. Okay. It is radiating from his back to the perineum and down to his legs. Okay. His legs were cold and they were numb, and he was very uncomfortable. And in fact, he said that his pain is 8 to 9 out of 10, which is excruciating. It is like someone has applied a G clamp. Have you applied a G clamp? It is that terrible. And he was just yelling. Okay. And in spite of this much pain, we still tried to ask him, how are you feeling? And how do you feel if we don't control your pain? And he was like, my God, life would not be worth living. So that was his statement. And he said that it's not worth living. And the problem with the pain is that means the most important thing is that you cannot see it. And most of the people don't believe it. And we feel that, our patient aise hi chilla raha hai, hamesha aata hai, chillata hai. And this is how we try to see, and this is how we try to have our loose talks. Right? So, but I'm hoping that as you meet Bill throughout this entire presentation, or a patient like Bill who comes to your OPD, then you will start believing them. And I can bet on that, right? You will start believing them. So everybody, until proven otherwise, we should assume he is trustworthy. So that is what is my statement, and I feel that. So coming to choosing analgesics. So how do you effectively choose analgesics? And if you ask me, there are very, very, very few randomized controlled trials related to these particular medications. Okay. You will hardly find any RCTs. You will find observational studies. You will find narrative reviews and all those things, or case reports, but very difficult. And there have been these medications, especially these opioids. It has been around for years. I can say, if you ask me, opioids, they are here for around more than 100 years. And why we are not having RCTs? Because they are very inexpensive and nobody is going to pay for us to do these clinical trials. So if you see WHO, World Health Organization, it formed a group of experts way back in 1984 at Geneva. And with these experts, they formulated certain term and certain thing. I think everyone is well aware of that. That is called as a World Health Organization 3-step analgesics ladder. So this is what I meant to say. So it has come. This is the second edition in 1996, and after that there was no edition. But the first edition came in 84 or 85 in Geneva, and they had classified medications into 3 steps based on their strength, and again to choose these medications and to start them based on the pain severity. If you see these 2 different slides, medications grouped by the relative strength. So they classified as weak, moderate, and strong group of medications. And if you see this based on the pain intensity on the NRS scale from 0 to 10. So if it is 1 to 3, okay, you can use this step 1, step 2 for 4 to 6, and step 3 for severe pain, that is 7 to 10. So this is how they had formulated this. And if you ask me personal opinion and my personal experience over these many years, I can say that almost, I will say 70 to 75% of the times you can just manage pain just based on these 3 steps. That's it. Means if you're practicing as a basic physician and you just want to take care of the pain, you can just do this. Unless and until you want to do some advanced pain management where we will be using most of the adjuvants, or you will be using intravenous ketamine or intravenous lignocaine, or you want to use methadone, which is a very, I can say, a specialized medication, or if you want to do certain interventions in the form of celiac plexus block or superior hypogastric plexus block or intercostal nerve block, then. But again, you ask me, I will say the conversion rates from this oral group of medications from the WHO to the other group of medications, that is IV medications in the form of morphine itself or ketamine or methadone, I will say after 80% of the times, means in 10% of the patients they need, and in those 10% of the patients, less than 1% of the patients need interventions. So that's what is my experience over these many years, and I'm sure. Now, if you go back and fall back to our bill, he was suffering from 8 to 9, and if you ask me, I can directly start the patient on this group of medications. That's the strongest opioids. Directly, I can start the patient on morphine. But some people say that, oh, well, the group 3 analgesics are very dangerous. I'm really worried about the respiratory depression, a lot of side effects. Well, now I'm going to teach, that is what I'm here for, a technique to make sure that your patient is safe. And when you start these medications, right, you start at an appropriate dose and titrate them accordingly to certain targets, which I will be explaining. However, I want you to focus on the fact that one of these groups, 1, 2, or 3, if you see, actually has a significantly dangerous medications. You might be thinking group 3 are very, very, very dangerous. But if you ask me, the group 1 medications are more dangerous than the group 3 medications, especially the paracetamol and NSAIDs, because they are easily available. They are over-the-counter medications. People just pop in. And if you pop in, like people really don't know whether to take it every 4 hours or whether to take it every 6 hours, they just pop in every 1 hour. And you can really have a significant, can say, overdoses, which can lead to liver failure. Or if you are taking NSAIDs, can lead to kidney failures. And to ask you, as an anesthesiologist, you might be managing post-operative pain. And if you see the post-operative pain guidelines, many of the guidelines and literature says that paracetamol, the maximum dose is 4 grams per day. But recently, the Center for Disease Control has recommended or reduced the recommended maximum per day dose of paracetamol from 4 to 3.25. So to be very precise, it is 3 grams per day. So I don't think you should be prescribing up to 4 grams. But if you ask me, when I was practicing anesthesia, way back 2000 to 2020, we used to give up to 4 grams. But recently they have changed it and it is 3 grams. Now people also say that, well, morphine, it's really strong. So I want to point out that it's not necessarily the case. What we know is every single analgesic has an equivalent analgesic potential to morphine, including the paracetamol also. Paracetamol also has an equivalent morphine. So we call it as an oral morphine equivalent. So those medications that are in group 1, you don't need to remember. You can just look at this table. So this table, if you see, 1 to 3, 4 to 6, so it follows the table itself. So if you look at paracetamol, if you are giving 500 milligrams, so it is equivalent to 1 to 3 milligrams of oral morphine. If you are giving tramadol, it is almost equivalent to 4 to 6 milligrams of morphine. And what morphine is equivalent? If you are giving morphine 7 milligrams, it is equivalent to 7 milligrams. So 4 to 6, 1 to 3. If you are giving even NSAIDs, so it is almost equivalent to 1 to 3 milligrams of morphine. It looks a bit confusing, I will give an example and make it very, very clear. The commonest medication which we use in our practice, I think everyone uses Calpol-T or Ultracet, right? Everyone might be using this medication, right? And if you see this, it's a very commonly prescribed, and acetaminophen or paracetamol is 325 milligrams and tramadol is 37.5 milligrams in this combination. So if you go back to this table, if you see this, tramadol falls in 4 to 6 oral morphine equivalents. I have taken it roughly 4 milligrams. And acetaminophen or paracetamol falls into 1 to 3 oral morphine milliequivalent or oral morphine equivalent, we call it as. So you take it 1 to 2. So if you add this, it always comes to 5 to 6 milligrams. It's not that I'm giving Calpol-T, so the patient comes and if pain is increasing more, then I would need to give him morphine 5 milligrams. No, he's already taking 5 to 6 milligrams of morphine, which is equivalent. Though it is not morphine, but if you take it, it is equivalent to that much equivalent to the morphine, that Calpol-T. So if his pain raises, then we need to give it more to these patients. When first starting an analgesic, we have to choose based on the patient's pain intensity. Okay, so that is how we usually start. So whenever the patient comes and if he is having moderate pain, that is 4 to 6, we usually start with step 2. That is either tramadol. Nowadays, I think it is banned. It is not used. It is available only in, I will say, cough syrup formulations. I don't know whether it is available, but in Mumbai, I have not seen it for the past 3-4 years now. So not even prescribed that medication. So this is how we use our medication. So this is how we choose. So coming to the dosing principles. So for the medications we use in palliative care, most of the drugs follow something called as the first order kinetics. And I think most of us are aware of this first order kinetics, zero order kinetics, or mixed kinetics, right? So first order kinetics, just to revise our pharmacology of second MBBS, is something of fixed percentage of the drug is eliminated. So if you are giving 100 milligrams and if you think 10% of the drug is eliminated, so every whatever half-life, it will be 10 or every 1 hour it will be 10 milligrams. If you are giving 50 milligrams, it will be 5 milligrams. So it is percentage based. So the same, we have a predictable response to that is, so if whatever drugs or most of the analgesics which we use in palliative medicine or palliative care, they follow the first order kinetics, except for methadone, which is an exception, and I will say a mixed order kinetics. Okay, so we can apply all our dosing principles to all our medications which we are using. So the side effects also follow this elimination and absorption and Tmax, Cmax, we will come to that. Okay, before going to that, first we will determine how to dose extra or a breakthrough pain. And everyone might be aware what exactly is a breakthrough pain. So breakthrough pain, one thing we have to remember is that it has to be the same pain which the patient is experiencing. It is not something, for example, I'm having a back pain and I'm having a good relief and all of a sudden I have an abdominal pain. So that is not called as a breakthrough pain. Okay, that could be classified as a crisis. It's a different thing. So breakthrough pain has to be the same pain. So if the bill is having a perianal pain and the backache, which is radiating to his thighs, right? If you remember the patient, okay, and if that pain increases in severity, provided your background pain is well controlled, then only you can call it as a breakthrough pain. If your background pain is not well controlled, again, you can call it as an acute pain crisis or an uncontrolled pain, either of it. So you remember this, okay? These differences are very, very important to manage us. So for the breakthrough pain, we usually need something called as a pro rata nata orders, PRN or SOS. In our country, we use it SOS, but SOS is not the right term. PRN is the right term. So before going that, we know that greatest analgesia is going to happen when the medication reaches something called as the maximum serum concentration. And we call it as Cmax. Okay. And we also need to determine how long it's going to take to reach that maximum serum concentration. And that time period, we call it as Tmax. Okay. I think you understood this, right? Cmax and Tmax. So going back to morphine, we commonly use morphine per oral. We never use per rectal. Very rarely I have used per rectal morphine. So per oral, per rectal, it is the same. If you see, it takes almost 60 minutes after administering the dose for the maximum concentration to reach. Okay. So what is the Tmax here? The Tmax is 60 minutes and to reach the Cmax. So Cmax is the maximum concentration where you will get the maximum analgesic effect or the greatest analgesia is achieved. So you might be wondering why it is taking 60 minutes for the oral dose, because when you swallow it, it goes into your stomach, then gets dissolved and then gets absorbed and that goes to the liver. First hepatic metabolism happens, then goes into the circulation, then goes into crosses the blood-brain barrier, then gets into the cerebrospinal fluid, then goes and acts on your mu receptors, which are located in the neurosynaptic junction. So all this journey takes a long time. So oral medication, the Tmax, the Cmax, to reach the Cmax, the Tmax is 60 minutes. So this is a long road, and this is why it takes so much time. So remember this 60 minutes, okay? Because we will be talking on Cmax Tmax only the rest of our presentation. So if you see based on our first order kinetics, for other routes, if you see the subcutaneous and all, the oral route is avoided. So there is no first hepatic bypass metabolism. Also, there is no absorption, there is no dissolution. Directly it gets into the circulation. Okay, so that's why here the Tmax to reach the Cmax is 30 minutes, and for the IV it is 15 minutes, because it all bypasses the entire GI tract. All right, so you got this point. We will talk about this half-life later on, but you remember the half-life is 4 hours. To be very precise and to memorize, I think you should memorize this. Per oral, Tmax 60 minutes. So that's why it takes 1 hour when you give an oral tablet to get the maximum analgesia. You have to wait for 1 hour. For IM or subcutaneous, you have to wait for 30 minutes. And for IV, you have to wait for 15 minutes. Some textbooks say that it is 10 to 15 minutes. Yes, every patient differs. So usually the range is 10 to 15 minutes. I usually don't advise to wait for 10 minutes. I give the maximum time. So you wait for 15 minutes so that our safety profile is widened. Then 15 minutes, if there is no effect, you can repeat the dose. We will come to that. So principle 1. So to summarize, our first principle is for extra breakthroughs, because we started with extra breakthroughs. We will go back to our patient again. Okay. We have to offer an extra dose every Tmax, SOS or PRN. Patient may refuse, no problem. But our duty is to make them explain. But do not use for extended release opioids. So this is not for sustained release or extended release. This is for immediate release opioids. Please remember this. I had seen many of the practitioners using this same principle for extended release also. Please, strict no. Don't use that. Okay. Now, extra dose, right? For PRN, if you see this, I told you, offer an extra dose every Tmax PRN, right? So why we need to do that? So when we are given this dose, he may not be having good analgesia, right? May not good analgesia. Some patients may have only 30% relief. Some patients may have 50% relief, and they may be asking for more. You can give a top-up dose, okay, at every Tmax. Then, if you see this graphical representation, if you give a dose of oral morphine to this patient after waiting for 1 hour, okay, so second dose, so we are expecting a higher level of plasma concentration or a higher level of serum concentration, okay, which is what exactly our patient may be needing to be able to experience the type of pain control which he is also hoping and which we are also hoping for, right? So that is what is for. So next consideration we will go is for constant pain. I hope I had cleared that. We will come to our later on question and answer sessions. Coming to the constant pain. That was for the breakthrough pain. Now there is a background pain which is very constant, right? The patient is experiencing this pain continuously. So dosing for constant pain, it relies on the pharmacological principle of half-life. So if you ask me, most of the people think half-life means 50% is removed from the body. No, it is 50% which is remaining in the body is the half-life. So if you are giving 10 milligrams, after 4 hours, 5 milligrams is remaining in this body. So that is the half-life. And this is for the drugs which follow the first order kinetics. It is not for the drugs which follow the zero order kinetics or mixed order kinetics, because then if you follow this, that's a different thing. I'm not going into much detail. So with morphine as an example, if you give a patient 10 milligrams, after the half-life, that is 4 hours, 5 milligrams of the dose would remain in the body. Just remember this. Okay. Our principle 2 is for constant pain. So to reduce the constant pain, we have to achieve a steady state. So to achieve a steady state, we have to dose our drug every half-life, right? So that is what is our pharmacokinetics. I hope you guys have understood. I think you guys are all with me, right? So to achieve this steady state, if you go back again to our second MBBS pharmacology, it takes almost, I will say, 5 half-lives. Okay, 1, 2, 3, 4, and 5 half-life to almost achieve 100% stability or plasma concentration. In morphine, it is every 4 hours, so it is almost 4 5 are 20. So almost 20 hours, if you see, almost we reach a stable medication of this or a steady state after 5 half-lives. So this is very, very important. So if you see this trough, so there's a peak, this is a trough. So concentration which is needed to control the pain, and this is a concentration where side effects start to occur. We have to maintain our drug medication in between these two. All right. And how will we come to know? By patient's presentation. Patient will say, "Abhi dard chalu ho gaya." So then we just top up the medication by PRN or an SOS both. Okay. At the same time, continuing our constant pain doses also, or round the clock medications. So the same thing also applies to the another group, that is the group 1 analgesics. They also follow the same pharmacokinetic profile, that is the paracetamol. And if you see the Tmax per paracetamol is 1 hour and the half-life is also 4 hours. Okay, so that's why if you go to a pediatrician, no, I was quite surprised when I took my son when he was a baby. I took one of my pediatrician and he said that no, it is not 8 hours. I used to think paracetamol is 8 hours or max to 6 hours, every 6 hours. He said no, every 4 hours you have to give to control his fever. So the same thing, even for your analgesics, we can give it every 4 hours. So after 5 half-lives, that is after 20 hours, we achieve a steady state. This applies for acetaminophen and also for ibuprofen. It is the same. 200 milligrams we usually start, and every 4 hours we can give. Not for 400 milligrams, because if you see our Combiflam contains 400 milligrams, I think. So morphine, as mentioned, follows the same profile. However, the unique part is that the best part of morphine is, or any opioid, is that there is no maximum dose. So that's why these are the group of drugs which are used when the patient comes in acute pain crisis. We don't use paracetamol or we don't use NSAIDs because they have a ceiling effect. After 75 milligrams, we can't give more diclofenac. We have to wait for 8 hours. Or after 500 milligrams or 650 milligrams of paracetamol, we have to wait for 4 hours. So, but for morphine, there is no, we have to, every 1 hour, we just keep on giving these medications. All right. So that is the beauty of this medication. Or every 4 hours, we can to achieve a steady state. So there is no maximum dose, and we can titrate this medication till you reach the analgesia or till you see side effects. So that is what I usually is my teaching to my students. So I always tell them that you just keep on giving till the patient is extremely sedated, or he hallucinates, or he nauseates. Okay. Otherwise, you just give till he has a good pain control, and then you convert that into oral medication. So that is how we usually try to do. I'm not going into Ramadol. Okay. So pain management. So starting doses. So now going back to our patient bill, he was experiencing 8/10 of the pain. So what dose to start with? So there are two main important considerations, because if you think whether the patient is opioid-naïve or the patient is opioid tolerant, there are two things, right? But he was already receiving previous analgesics, so we will not call that he's naive. But again, the question is that many of my students and many of the people who come to me as an observer, they ask me, sir, how much to start, 5 milligrams or 10 milligrams? It depends. So usually if the patient is less than 35 kgs, I usually start with 5 milligrams. I start very less. Otherwise, I usually give them 10 milligrams every 4 hours. So that is how I usually start, unless and until they're very old or very, very frail. Okay. Otherwise, we usually starting dose is 10 milligrams. So it is very safety. You can start the patient. Okay. If you see the starting dose for this patient he was already opioid tolerant because he was taking tramadol 100 milligrams every 6 hourly. Okay. So that comes to around 400 milligrams in 24 hours. And if you see daily oral morphine equivalent dose, 24 hours is 1:10 tramadol to morphine conversion. So it comes to 40 milligrams. So he was already taking 40 milligrams of morphine in 24 hours. So what we do is that whenever they come with inadequate pain control, we double the dose. So of the 24 hours, or the dose which is taking, if he's taking 5 milligrams, we double it to 10 milligrams. So 80 milligrams. To make it 80 milligrams, 24 hours, if you divide it by 4, it comes to 6 doses. If it comes to 6 doses, there is nothing called as 12.5 or something like that. So either it is 10 milligrams or 15 milligrams. So we take 15 milligrams into 6, so that comes to 90 milligrams. Morphine, immediate release, 15 milligrams per oral Q 4 hours. So that is the dose we start. Okay. But what about for the extra or the breakthrough pain? If you go back to the pharmacokinetics, what I told you, you have to offer this dose every Tmax. And Tmax of oral morphine is 60 minutes. So every 1 hour we have to give. And how much to give? Usually it is 10 to 20% of the total dose in 24 hours. So how much it was? 15 into 6, it is 90 milligrams. So 10% or to 20% of 90 milligrams is 10 to 18 milligrams. It is somewhere between that. So we take it around 15 milligrams. So we are giving him 50 milligrams every 4 hourly. At the same time, 15 milligrams Q 1 hourly also as a SOS dose or a PRN dose. If you see, this is his prescription. All right. So it is coming to 9 to 18 milligrams. That is 10 to 20% of breakthrough dose. So it is morphine immediate release 15 milligrams per oral Q 1 hourly PRN. Right. Before next breakthrough doses, I always ask my patient, I always tell them to write it on a sheet of paper, or if we don't have a pain diary, we are out of stock. Actually, we used to have it, but I always tell them to write it on a paper and get back to me. So, did you record the last dose? What was the pain severity that time, and what is the pain severity now? Any effects you didn't like? Side effects. See, whatever he doesn't like are the side effects. We usually take it that way. And you report it to a nurse or a doctor. That is how we usually advise. So now if you see this 24-hour circle, all right, it starts at 6, okay? So at 10 a.m. he has taken 15 milligrams. At 11 a.m. he has taken 15 milligrams. At 12 he has taken 15 milligrams. At 13 he has taken 15 milligrams. But if you see this yellow R is round the clock doses. That is routine doses, Q4 hourly doses. So 10 बजे के बाद आता है 2 बजे, right? 2 बजे के बाद आता है 6 बजे. So that is how he has to take his dose. This white R is PRN doses or SOS doses. Okay, so you just remember this. So he's taking almost 6 round the clock doses, as well as at the same time he has received almost 3 doses. That is how usually they chart and tell you. So this is the pain diary. This is the simplest thing. What time, what was the severity, and the dose he has taken. And if you see at 2 o'clock, he has taken a breakthrough dose, as well as he has taken his regular dose also. No problem. You can take that. No problem. So opioid side effects, the commonest is, the primary side effect is constipation, because the mu receptors act on the brain. The mu receptors are also there on the gut. They decrease the mobility, because of which they have constipation. It also causes dry mouth, nausea, vomiting. So these are the commonest side effects the patients usually have. But if you ask me, almost all are the reversible side effects. Constipation is a side effect which stays with them. So that's why I usually prescribe them for the nausea, haloperidol or metoclopramide, SOS. I never give them round the clock. Haloperidol, I usually give it SOS, but haloperidol, I give it for 3 days, 10 milligrams, provided it is not contraindicated to the patient. So 10 milligrams, Q8 hourly, I give them for 3 days, and then I tell them to take SOS. But haloperidol always 0.25 to 0.5 milligrams, SOS 1 hour, I tell them. And for constipation, I ideally use only one group of medication, that is a osmotic laxative. But we also get a beautiful laxative, that's a Crimafin Plus, which has a picosulfate, which is a stimulant also. So that is the best laxative, because here you need a stimulation also, because it is the gut which is not mobile. So you need to stimulate the gut. So that is the best laxative which we use. All right. So for initial dosing, we use the pharmacokinetic profile of our medication. So this allows for the safe dosing and provides the most efficacy we can give it to our patients. And also we have to anticipate the common side effects. The most common is the constipation as well as the nausea. After this, now let's talk about the titration. How are we going to titrate this? So on day 1, the follow-up patient. So patient comes to you, Bill comes to you with pain of 6/10. He was having 8/9. Now he comes with 6/10, no side effects. See, this is just day 1. Usually in outside, they usually admit or they follow up the patients every day. Sometimes it becomes difficult for us. You might be having this question, how you can follow the patient every day. I usually follow the patients every 3 days, or I call them after every 1. I usually do that. But this is presentation, so I'm just telling you every 5 days so that you can understand the titrations. So morphine use in the last is, he has used 6 doses, that is around the clock 90 milligrams, and he has used 6 extra doses, so 90. So total he has taken 180 milligrams. So now new treatment will be 180 milligrams divided by 6. So we can give him 30 milligrams Q4 hourly, and you add 10 to 20 milligrams, that is for the breakthrough pain. It comes to around 18 to 36. Again, we can take it as a 30 every 1 hour. So his new prescription is 30 milligrams IR, that is immediate release, 4 hourly, 30 milligrams IR, 1 hourly SOS. So day 2 he comes back, his pain becomes 4/10, no side effects. Morphine use, 6 doses is 180 milligrams. Again, he takes 4 doses extra. So total becomes 300 milligrams. Again, new treatment. If you see all those 300 milligrams, you divide it by 6, it comes to 50 milligrams. So his new prescription will be 50 milligrams Q4 hourly, 50 milligrams Q1 hourly SOS. Day 2. Day 3, he comes with pain 2/10, no side effect. So 2 is a very good pain control. So if you see, he has taken 6 doses, 300 milligrams, 2 extra doses, 100 milligrams. So total use is 400 milligrams. So 400 milligrams, you divide it by 6, it comes to 65 milligrams every 4 hourly, and then 65 milligrams Q1 hourly. I hope you are understanding this. But his wife comes to us and tells that he's sleeping a lot. So now there are 2 things here. Either he's catching up on his insomnia or exhaustion because of his pain, he was not able to sleep for all these days, or because of the excess medication, he is intoxicated. So how to differentiate? So we need to ask this, whether it is difficult to wake up. A patient who's catching on insomnia or exhaustion, it is very easy to wake up. He will have his eyes wide open. He's not confused and his speech is not slurred. But if he is because of the excess medications or intoxicated, he has all these four things. So ask his wife whether he's having all this. So we call this as a catch-up technique, titrate to control the pain. And this is the safest possible technique which we can use to control the pain. Now coming to the maintenance. So how will you maintain these medications? So now we know that Bill requires almost, if you go back and see this, he almost requires 65 milligrams, that is almost 400 milligrams, okay, of in 24 hours, okay. But if you see, he's waking up at 2 a.m. to take his night dose. So what we can do is that rather than telling him to wake up at 2 in the a.m., we can give this double dose. And there is a literature to support this also. We can give the double dose at the bedtime, that is at 10 p.m. and tell him to take this. What will happen at the most? He will be sedated. And what we want, he should have a good sleep. So that is what we want. I think that is the best thing we can do. And I usually advise my patients when they say, and they come, they say, "Arey, doctor sahab, raat ko 2 baje utھ ke khana pad raha hai humko dawa." And I ask them, okay, no problem. You are not having any side effects. You do one thing in the night. For example, if you are taking 10 milligrams, so you make it 20 milligrams and sleep. No problem. So that is how we usually try to give this. So it gives an additional plasma concentration and you can sleep without pain. So extended release preparation. So we want to maintain is stable pain, and no one wants to eat 6 tablets per day, right? So if we give extended medications, we can just give it 12 hourly. So if you go back and see, he was receiving almost day 8, okay? So he was almost receiving 400 milligrams plus 5 doses extra. So he's receiving almost 725 milligrams. So make it 720 and you divide it by 2. So it comes to around 360 milligrams extended release or sustained release. We have sustained release morphine in our country. So every 12 hourly we give it. But this breakthrough medication should be immediate release. And if you calculate, it falls in between 72 to 144. So that is around 100 milligrams. So 360 milligrams every 12 hourly of immediate extended release or sustained release medications, and immediate release 100 milligrams every 1 hour you can take. So this is what is his final risk. Okay. Now, our most important concern is clearance. We are giving so much dose, and what happens? Most of the patients are dehydrated. Most of the patients may have some other comorbid conditions. What will happen to his clearance? So if you go back to the metabolism or elimination, the morphine is a water soluble and fat soluble or fentanyl and methadone. They are all inactivated by liver. So we are not at all bothered about fentanyl and methadone in liver kidney failure, but we are bothered about the morphine because it is cleared by urine. So if you see, it is metabolized in the liver by glucuronidation, okay, to M3G or M6G, okay, morphine 3 glucuronide or morphine 6 glucuronide. And if you see, M3G is the problem maker, which has a more of a CNS effect. And if he has dehydration or renal failure, or if he is dying, and if he is having oliguria less than 500 ml, I usually decrease by 50%, or if it is less than 250 ml 24 hours or anuria, we stop it. And we continue the patient only on PRN. Because one dose it will be there in the body, because M6G is a very potent analgesic. Okay. And almost 95% of it is excreted by the urine. And if his urine is falling, it is not getting excreted, it is staying in. So if he needs the medication, that means the levels have come down. So that's why he's asking for the PRN dose. You can manage the pain by PRN dose. So clearance concerns for water soluble, not for lipid soluble. And if it is less than 250 ml, we usually don't give and we continue only PRN dose. So going back to Bill, he had incomplete spinal cord compression. He had leg weakness. He is moving with aids. He has incontinent of urine as well as stools. So his constant pain was controlled by 180 milligrams. His incident pain is controlled by 30 milligrams immediate release. And we have added in co-analgesics also, amitriptyline and zolitonic acid monthly. So this is what, when we had a home visit, my mentor had a home visit. He was cheering with his friends. He opened up a wine and he told them that, please kindly, you can use my story to your teachings and to your students. So to summarize, use the pharmacokinetics to guide analgesic dosing and control pain rapidly and safe. And the pearls are, the first order kinetics are very, very important. You should know this. So for optimal efficacy and safety, titrate to the effect or to toxicity. I always tell them either to the effect or toxicity. Start low, dose every Tmax for PRN, titrate using catch-up technique. Maintenance dose should be every half-life. Steady state is achieved after 5 half-lives, and elimination is also after 5 half-lives. Thank you very much.